Endocrinology Diabetes Mellitus Lesson 2. In this lesson, we are going to learn about complication and treatment of the diabetes mellitus. Complication of diabetes mellitus. Microvascular complications are retinopathy, nephropathy, neuropathy. Macrovascular complications are stroke, ischemic heart disease, peripheral arterial disease. Let's learn about acute complication of diabetes mellitus. Hyperglycemic comatose state, diabetic ketoacidosis, hyperosmolar hyperglycemic state. DKA usually occur in type 1 diabetes mellitus. It occurs due to insulin deficiency or it can occur with lack of insulin. It is precipitated by increased stress, surgery, infection, exercise. Hyperosmolar hyperglycemic state HHS occur in type 2 diabetes characterized by hyperglycemia, hyperosmolarity and dehydration without ketosis. It is precipitated by sepsis, stroke, congestive heart failure, renal failure, trauma, drugs. Presence of small amount of insulin prevent the development of ketosis by inhibiting lipolysis. Clinical feature of DKA: hyperglycemia symptom, polyuria, polydipsia, weakness. Acidotic symptom, air hunger, nausea, vomiting, abdominal pain, Kussmaul respiration, acetone odor breath. Hyperosmolar hyperglycemic state. Onset is insidious, preceded by weakness, polyuria, polydipsia. History of decreased fluid intake, history of ingesting large amount of glucose containing fluid. Dehydration symptom or the static changes lead to loss of consciousness, lethargy, confusion. Comatose due to high serum osmolality. Kussmaul respiration absent unless the underlying precipitant caused by metabolic acidosis. In diabetic ketoacidosis, arterial blood gas. Anion gap metabolic acidosis with possible secondary respiratory alkalosis. If severe vomiting or dehydration, there may also be a metabolic acidosis. Hyperosmolar hyperglycemic state HHS, arterial blood gas. Metabolic acidosis absent unless underlying precipitant lead to acidosis. For example, lactic acidosis in myocardial infarction. In DKA, urine positive for glucose and ketones. In HHS, negative for ketone unless there is starvation ketosis and glycosuria is present. Treatment of DKA. Airway breathing circulation are first priority. Monitor degree of ketoacidosis with arterial gas, not with blood gas or serum ketone level. Anion gap is the most important endpoint used to monitor the resolution of the metabolic acidosis. HHS, hyperosmolar hyperglycemic state, negative for ketone unless there is starvation ketosis. Glycosuria is present. Treatment is same as resuscitation and emergency measures as DKA. Treatment of diabetic ketoacidosis and HHS. Its rehydration therapy is first. In DKA, 500 ml per hour for 4 hours, then 250 ml per hour for 4 hours normal saline if mild to moderate deficit. 1 to 2 liter per hour normal saline if severe deficit. Switch to 0.45% sodium chloride once euvolemic. Continue normal saline if corrected sodium is low or rate to fall of plasma osmolarity greater than or equal to 3. Once blood gas reaches 14 mmol per liter, add dextrose 5% or 10% to maintain blood gas of 12 to 14 millimole per liter. Hyperosmolar hyperglycemic state treatment, rehydration therapy. IV fluid 1 liter per hour normal saline initially. Evaluate corrected sodium If corrected serum sodium high or normal, switch to 0.45% NaCl. If corrected serum sodium low, maintain normal saline 4 to 14. DKA insulin therapy critical to resolve acidosis, not hyperglycemia. Do not use with hypokalemia until serum potassium level corrected greater than 3.3 millimole per liter. Use only regular insulin 0.1 unit per kilogram per hour. Check serum glucose hourly. Hyperosmolar hyperglycemic state. Insulin therapy acute by monitoring plasma osmolality, adding glucose to infusion once blood gas reaches 40 millimole per liter, using correct concentration of saline. Switch to 0.45 sodium chloride once euvolemic, as urinary loss of electrolyte in osmotic diuresis are usually hypertonic. Increase saline concentration if falling too rapidly. Potassium replacement in DKA. With insulin administration, hypokalemia may develop. If serum potassium less than 3.3 millimole per liter, give 40 millieq per liter potassium replacement and hold insulin until potassium level greater than or equal to 3.3. When potassium 3.3 to 5, add KCl 10 to 40 millieq per liter to keep potassium in the range of 3.5 to 5. Hypoosmolar hyperglycemic state potassium replacement therapy. Less severe potassium depletion compared to DKA. If serum potassium less than 3.3, give 40 millieq per liter potassium replacement and hold insulin until greater than or equal to 3.3. When potassium 3.3 to 5, add KCl 10 to 40% to keep range of 3.5 to 5. If serum potassium greater than or equal to 5.5, check potassium every 2 hours. Bicarbonate therapy in DKA. If pH less than 7 or if hypotension, arrhythmia or coma is present, give bicarbonate. One ampule contains 50 millimole in 200 ml dextrose 5 solution or sterile water if available over 1 hour. Repeated every 1 to 2 hours until pH greater than or equal to 7. Do not give if pH greater than 7 is risk of metabolic alkalosis. Can give in case of life-threatening hyperkalemia. Thank you. Please subscribe for more lessons.